It's great to see so many faces that I've spent time with and met with. So we're getting there. There's a lot of people in the room that I've seen throughout the scoping exercise. So as you can see, my name's Helen Sowden and I'm the Helen Brain CNS Programme Manager. Started posting in January, working in partnership with Helen. I work for Yorkshire and Humber Mission Support in the Service Delivery and Assurance team, and we're very fortunate to work in partnership with such a fantastic and well-regarded charity. So I feel very privileged to be in this position to direct this programme of work. A little bit about me: I've got a clinical background and spent most of my time there after working as a clinician in public health, commission in healthcare and public health services, before moving over to Yorkshire and Humber Commission Support, where I took this opportunity to work on this programme. Okay. So just a little bit of context, really. This evidence here that is highlighted on this slide is taken from the Millen Regional Diagnosis Report, which was published this year. And basically, the report is a programme of research that looked at retrospective analysis of over 85,000 cancer patients' data sets over a 7-year period. It's to do with their interactions with the NHS. And of those people, 9,000 patients with brain CNS cancer data sets were looked at over 2003 and 2004, and this is what the evidence was saying. So brain tumour and CNS cancer, like it says, is a disparate collection of tumour types with very different treatment outcomes and very different treatment profiles. So in terms of complexity, when we talk about rare cancer, try to put into context really. A large proportion of patients experience limited survival, but those patients, there were a proportion of patients that lived for at least 7 years. So there's something around the comorbidities and the life and the health needs on top of the brain CNS cancer that they might be experiencing in terms of support they need. And approximately 2/3 of all brain CNS tumour patients experience other inpatient morbidities. So there are things around musculoskeletal problems, circulatory problems, and the nervous system problems as well. So I hope you can all see that. Probably all very familiar actually with this map, with this geography. The colours represent the various CCGs. The dots represent the various hospitals, and the green bit in the middle is Hull, which is the tertiary centre, which the local hospitals refer patients into the MDT in Hull. So as you can see, in terms of complexity, not only do we have a complex geography and the rurality that's involved within that, we've got a huge number of CCGs, we've got a lot of local authority colleagues which aren't mapped on there because I haven't had a chance to put that on, but there's an acknowledgement that there's local authority boundaries within that as well. And also in terms of patients and the carers and the journeys that they have to make to be treated in Hull are coming from quite significant places in terms of where they live to receive their treatment and to receive their care. Yes? Oh, sorry. I think I keep moving back. I'm sorry, if I apologise for that. I'll go closer. Okay, is that better? Okay. Thumbs down if you can't hear me. Okay, so this slide here is it's taken from the annual report from the brain CNS tumour MDT, and it's just to give you a representation of and clear numbers in relation to the hospitals that are referring from the various localities into the MDT. Oh. And as you can see, there's varying numbers in terms of people referring into the MDT, but it gives you an idea of the different localities and who's referring into it. But also for some of the geography, in terms of Vale of York, for example, they may refer to Leeds into that MDT, and sort of north of the patch as well would refer to South Tees Hospital, and for specialist treatment people also might be referred to Sheffield as well. Okay, but just gives you an idea in terms of numbers and the flow through into the system. So, about what we've done so far. So, like I said, we've been in post since January. We've got a steering group together, which is trying to drive the programme forward and make some partnership decisions around how we move forward with this piece of work. We've got representation from Ali, who's our patient rep on the steering group. We've got representation from various Macmillan colleagues. We've got a communications lead and patient involvement lead. We've also got senior commission support team members within that steering group. And also Sue Brigglesworth. I don't know if I can see Sue here today.
No, I'm here, Sue's.
Hello, Sue. It's not Sue, obviously, this gentleman is representing Sue. So Sue's also on our steering group as well. So we've got a real mix of partnership commitment to drive this programme forward, but also giving a really good mix of ideas and ways of working that are innovative and bring a variety of flavour to some of the discussions around where we go with this programme and some of that challenge and that kind of decision-making process. But we've been meeting quite regularly lately because we've been quite busy. So we're meeting every month, but if people want to understand a little bit more about the direction of some of those meetings and what was discussed, if you can get in touch, then that's fine. What I've been doing and Lorraine's been doing is meeting with as many of you as possible along the continuum of this pathway. So right from pre-diagnosis to survivorship and end of life, all the practitioners, all the professionals out there, patients and carers, to really get a rich, deep understanding of what the issues are. There's some really great stuff going on out there, and there's some great acknowledgement from the patients and carers about the support they're getting from the treatment once they're in treatment. But there's some concerns in terms of patients saying that some of the wraparound care and the treatment support they need at home and all the stuff Lorraine's touched on as well, which I'll go into more detail later. We also held a patient mapping, we held two actually, to really see if we have the parallels in terms of the clinical perception of the patient pathway need and the patient's perception of what care was received and what care was needed that might have helped that wasn't there. I've touched on the fact that Caroline's our patient involvement coordinator. We'll be hearing from Caroline later, so she's got really great stuff to share in terms of carer and patient stories and experiences. And Caroline's gone on to interview 9 patients and 7 carers, some with malignant and some with benign tumours as well. Okay. I think I've touched on those things there. So what's coming out of the scoping and the mapping? So in relation to pre-diagnosis, some of the stuff you've heard already in terms of Lorraine talking that through, which is good because we're getting the repeated story. Something obviously is around the real complexity and the difficulty GPs have in diagnosing this cancer. Like Lorraine said, they may not see many patients with this cancer in their careers, and they may not find it easy to refer based on patient symptoms. Patients can come and see the GP with a whole variety of problems, from cognitive problems, from expression, feeling anxious and stressed, to having balance problems, to feeling low mood. There can be all manner of pathways in which the GP would think to refer people onto. So it's not easy. So it's not about saying GPs are missing and not referring appropriately. So it's saying it's really tricky to do, and I think there's an acknowledgement from secondary care that they can support around helping primary care about what that could look like and what learning and development could be put in place around supporting our GPs. A high number referred by A&E, sometimes from what I've been picking up, that's to do with the fact that some patients, it's not appropriate to be on a 2-week wait. It doesn't feel right in terms of the way that people are presenting in front of them and the acute symptoms that people are presenting with. Sometimes A&E feels as if it's the only route that primary care has in terms of where the patient is in that consultation. And also, I think for me, it's that the GPs are saying that let's look at that. What could we do? And I think if it would be easy to sort out, it would have been done by now, and I think there's some scope and opportunity in relation to the tool that Macmillan are and have developed in relation to that, like Lorraine touched on earlier as well. Varied access to diagnostics. In some areas, GPs can refer to the medical assessment unit for some of those investigations and diagnosis, diagnostic testing rather. And in some localities, GPs don't have that provision and don't have that referral system. So there's something around inequity in terms of that first diagnostic into the system stuff that is happening throughout the patch as well. We've touched on communication being timely and detailed, and that's both for primary and secondary care back to primary care, and also in terms of patients. Some of the patients say that if they've been seen at a local hospital and where they know there's a suspicion that there's something that is wrong and that they're going to have to see the specialist over in the MDT in Hull, they're saying that time lag between that first discussion with the practitioner in the local hospital and then waiting to see the specialist, the MDT, is just so hard for them, so difficult for them. And they've talked about solutions. So they've talked about we'd need some information about that. Not sure what it would look like and how we would share that, but something around it's being acknowledged from the patients, but also the practitioners are saying that to me as well, that what useful information can we share with people at that point where people are referred through to the MDT in Hull. And I've touched on inequity and equality within the region, and that's through the whole of the pathway. And I think our specialists that are here today will talk about that more solidly in relation to the lack of specialist rehab within the whole of the system and the specialist side of the rehab that is available locally. And some of the things that the patients and carers are saying are, I'll be repeating because Lorraine's touched on those things as well. But I think what I want to pick out from there is that hindsight, they said, looking back, you know, there was something really wrong, and it wasn't just a headache, or it wasn't just I just couldn't concentrate. It was the fact that we've got so much learning from the patients that we could build on to be able to get things provided in a better way that makes sense and is co-created with our patients. In terms of diagnosis and treatment, I just want to extract a few things from here because I've been given the yellow card. But I want to pull out from here that for me, patients that are repatriated back to their locality may have to be placed on a medical ward or a bed somewhere within the hospital that doesn't necessarily have the specialist rehab skills to enable someone to feel ready and competent and confident to get home and to function. And that's not about saying that you know, that's about saying what can we do to improve that, what learning can we pick up from the therapist team in the Hull in terms of the skills and the knowledge that they're building up, and we missed a trick in terms of sharing that expertise with you know, the generic practitioners in the other areas as well. Clinicians talk about that it's really kind of hard to find the time to talk about the patients' desires, wishes and their future care plans because of the limited time that they sometimes have with patients. I'll shoot through. You have got your slides, so I'll shoot through because I'm just dreading having the red warning here. But I just wanted to pull out that people really talk about the positive experience they've had from the allied health professionals and the counselling services, and the difference it's made to their quality of life has just been enormous, absolutely enormous. We've touched on a lot of that in terms of the variety of the patch. I think there's some opportunity in terms of self-care and managing and ongoing living with cancer and living with brain and CNS and cancer in terms of how we integrate the health and social care agenda, how we describe need rather than brain tumour and CNS cancer, how we describe what people have difficulties are having with function, and it be needs driven rather than professionally led driven, which I think some of the specialists will also touch on later today. Next steps. consolidating all that we learned from today. You know, this is just part of the story. We need to hear back from you how we got it right, some challenges around that, before we triangulate all the information we've got. Just 1 minute, give me 1 minute more. There are... No. Yeah, both of our children were 2 weeks late. There's gaps in the scope, and I think there's something around further work with carers, further work with local authority, further work with some of that intelligence around palliative care. And then we need to start to work the programme up in terms of what we're going to deliver, what we're going to do, and what's going to be the priority for the next 2 years. I need to get to the next slide. This picture, it took me ages to do because I'm not an IT wizard. But I was on holiday lately and I went to visit this mosque. It's the most amazing building I've ever been to. It holds 44,000 worshippers. It took 7 years to build. It had something like 1,300 carpet rotters to make this enormous carpet within the main hall. It's got a chandelier here that's made with 24 karat gold, and it's got all these beautiful columns that have mother of pearl inlaid in it. I suppose what I'm getting at with this is that it took vision, it took skill, the right skill mix, the right commitment, the right team, and the right people together that really were passionate and driven to get this thing built. And I think we've got such a fantastic team, or we've got some fantastic commitment in the room, that we might never get this opportunity again. We really, really need to work together and produce something that is truly magnificent for the patients and carers as well. So there we go. Thank you.